जी.
So there is an ST elevation. If you can see the above AC here, there is ST elevation in lead 2, 3 AVF with reciprocal changes in 1 and AVF.
AVF.
And there is also some changes in lead V1, V3, V1, V2, V3. So we did the right sided as well. So किधर आप क्या ये तो ये basically बता रहा है large inferior wall MI. This is large inferior wall. By means of small inferior wall, MI means isolated inferior wall. When there is just elevation in lead 2, 3 AVF. By means of large inferior wall MI, when there is a component of early infarct, either there is a lateral wall MI or either there is a posterior wall MI along with inferior wall MI. So this is a large inferior wall MI. And if you can see the elevation in lead 3 is more than lead 2, then it shows early infarct. So it is giving a clue that the most possible artery which is occluded in this case will be right coronary artery. So we did angiogram of this patient via right radial approach. Take 2 diagnostic catheter was shown, and you can see here that there is a total occlusion of the proximal RCA. Then, but just by putting the coronary wire, the flow is achieved. Later on, we put a stent, we did a ballooning, this proximal lesion was also covered. So 2 hours after the procedure, when we did his ECG, there was a drastic reduction in the ST elevation in lead 2, in lead 3, AVF. So the myocardium was salvaged in a very appropriate time. So from this, what we get, time is muscle. If you treat in time, you will save the muscle. My name is Dr. Cardiology-Dr Asifullah. I am Senior Registrar, DH2 Teaching Hospital, KD Ward, and I am very much obliged to Sir Asif and respectable faculty member who has given me this opportunity to discuss a very real and pressing problem that we are facing in DH2 Teaching Hospital. That is the management of acute myocardial infarction. So today the topic of my presentation is how to improve the outcomes in acute MI at DH2 Teaching Hospital and change and have this paradigm shift from streptokinase-based care to the evidence-based care. That is percutaneous coronary intervention. So the objective of this presentation are multiple. Firstly, I want to brief my faculty member about the existing cardiology infrastructure and manpower at DH2 Hospital, Kohar. Secondly, I will share outcome related data including morbidity, mortality, referrals from policies. Thirdly, I would like to explain what world is doing and what we are doing with myocardial infarction. And lastly, my aim is to justify why this dedicated cardiology unit is not only functional but essential for the population we are serving right here in Kohar. So DH2 Hospital, KD Kohar has been approved as a Category A teaching hospital in 2017, which is catering a large amount of population. Despite this, we currently do not have cath lab services. We receive a significant number of acute myocardial infarction patients from the far-flung areas of South KPK, that is from Hangu, Dals, Dawaba, Sadda, Purampara, Chinar, even Karak, Banu. Sometimes we are receiving patients from Banu, though they have cath lab there as well. And most of whom are treated by streptokinase. And due to lack of PCI facilities, many patients are referred to Kishar, often late, unstable, and are at great financial and emotional cost. As a result, what we are getting a very high mortality and morbidity. Morbidity in the form of heart failure, mortality in the form of cardiogenic shock, morbidity in the form of reinfarction, and lastly, longer hospital stays. So, we have a dedicated cardiology unit. Total, we are having 30 beds, among which 10 beds are dedicated solely for the CCU purpose. A CCU, built in a CCU. 5 beds are monitorized bed in female side and 5 beds are well equipped on the male side. Apart from this, we are having general 20 beds, 10 on the male and 10 on the female, which we have kept after the patient is stabilized, we ship them into those homes. Basic monitoring facilities in the form of monitor or ECG is available. Apart from it, unfortunately, we are lacking plenty of facilities in the form of temporary pacemakers, CVP lines, which are basically needed in CCU. From a manpower perspective, we cardiology unit is having around about 7 FCPS qualified consultants, 3 medical officers who are also very trained, and these services are provided by the senior registrar and consultant who remain available around the clock, 24/7 availability. You won't find our unit, alhamdulillah, कि उसमें कोई भी डॉक्टर ड्यूटी पे मौजूद ना हो, सारे 24/7 available होते हैं. Services we are providing is in the form of management of the acute coronary syndrome, both stent and end-stent. We are dealing with patient having arrhythmias, heart failure, hypertensive emergencies. We also stabilize the critically ill patients and arrange timely referrals to the tertiary care centers where advanced interventions like PCI are required. Now, sir, the next slide is very astonishing. This is the yearly data, 2025 data, which is showing admissions per month in the cardiology unit. So if you can see the graph, in January we have 349 patients, in Feb 320, in March 300, April 225, May 320, June 287, July 264, August 258, September 257, October 270, November 334, and December 358. Of them, 300 patients are admitted in the cardiology unit per month in the year 2025. Among these patients, every month, roundabout on average, we used to see cardio over 9 to 10 patients. Streptokinase is given to 58 patients in the month of January, 65 in the month of Feb, then on the average of round about 37 to 38 whole year. Similarly, the referral to the PCI was done in patients about 95 in January, February it is 85, March 38, April 65, then again there is a peak in May and June, ranging about 84 to 97%, July 82, August 42, September 79, October 52, November 66, and in December 28.
ये grey is the PCI referred
Yes,
people.
these are the जो directly referred हुए हैं, जिनमें हमने even streptokinase दिया भी नहीं है, जो आए हैं अपनी मर्जी से गए हैं.
ठीक.
और जो streptokinase वाले हैं, सर total streptokinase वाले हमारे पास जो है वो है 471 patients, and for PCI referral this is 863 patients.
In last year.
In last year.
काफी ज़्यादा है.
ये बहुत ज़्यादा है. और सर अगर आप EHA का डाटा खोलें तो वो कहते हैं कि जो टर्शियरी केयर सेंटर होता है उसमें एटलीस्ट 400 एंजियोग्राफी बड़ी जो हाई वॉल्यूम सेंटर्स हैं और 75 PCI पर मंथ होने चाहिए, पर ईयर होने चाहिए प्राइमरी. तो ये उससे डबल ट्रिपल डाटा. लेकिन इसमें से बड़ी सा बात भी है, our mortality is 117 in the whole 2025 year, which is quite huge, and they all died because of acute myocardial infarction.
Unavailability of
heart failure और उनके patients include नहीं है. So the pointer is that the total admissions in the year 2025 were 3,555, among which DC cardioverted were 106. They were included all type of arrhythmias like VT, SVT, and FM streptokinase were given in 471 patients. Referral for primary PCI were done in 863, and at last mortality were 117. So the purpose of showing this data was that the phrase "time is muscle" is not just a slogan, sir. It's a proven biological fact. For every minute of delay, Sabit, myocardium is irreversibly lost. Delayed reperfusion lead to the larger infarct size, poor LV functions, heart failure, arrhythmias, and eventually the patient gets succumb to death. So our current system unfortunately causes delays at the multiple. What is the pathophysiology of STEMI occurs due to the rupture of an atherosclerotic plaque followed by the acute thrombotic occlusion of the coronary artery. So this results in the complete cessation of blood flow to that particularly LV segment. And within the 20 to 30 minutes, the apoptosis and myocardial necrosis begins. So without timely intervention, this subendocardial ischemia will progress to the transmural infarct. मतलब सारा उसका जो MI का जो myocardium है, वो सारा infarcted हो जाए, जो later on scar develop करे और akinetic हो जाए. फिर हमारे पास वार्ड आते हैं, हार्ट फेलियर होते हैं, फिर उनकी पड़े रहते हैं, तो फैमिली के भी बर्डन रहता है, इमोशनल बर्डन भी रहता है. The cornerstone of STEMI management is early reperfusion. There are only two proven perfusion strategies. The first one is fibrinolysis, which attempts to chemically dissolve the clot, and the another one is mechanical dissolution of the clot, which is done by the means of primary PCI. Now the key question is, what strategies to use, and how fast it should be used. So if we compare the global evidence, we will talk about evidence in cardiology. Multiple landmark trials have been done, which compare the fibrinolysis with primary PCI. The PAMI trial showed significant lower mortality and reinfarction with PCI. The DYNAMIC-2 and PRAG-2 trial confirmed that even within inter-hospital transfer, for example, if a patient presented to DHQ hospital, transfer timely to the tertiary care hospital, even says, the guideline says, this trial says that shift that patient as soon as possible. And the STREAM trial then showed that if the PCI is not possible in your center, adopt the pharmaco-invasive strategy. Give thrombolytics, fibrinolysis, and then transfer that patient. What is the time limit of transferring? I will discuss it later. So meta-analysis including the tens of thousands of studies on these patients ensured that the primary PCI reduces the mortality by 25 to 30% compared to the fibrinolysis. It also reduces significantly the infarct size. It decreases the chances of intracranial hemorrhages, and importantly, the PCI preserves the LV systolic functions. Now here comes the importance of time. Guidelines emphasize the time targets. The पेट से नहीं बनाया किसी ने. If primary PCI can be performed within the 90 minutes of first medical contact, it is the preferred strategy. And even up to 120 minutes, PCI remains superior. The benefit of thrombolysis rapidly declines with time. It is only beneficial, sir, in the first 2 to 3 hours. जो हमारे पास आ जाते हैं, जो गाइडलाइंस कहती हैं कि आप 12 आवर्स के अंदर अंदर आप दें, अगर उसको इस्कीमिक पेन है तो एक क्लास 1 रिकमेंडेशन है. वो ठीक है, क्लास 1 है, आपकी मजबूरी है, लेकिन 2 से 3 घंटे से अगर वो टाइम ऊपर चला जाए तो फिर वो मायोकार्डियम इतना सर्वाइवल नहीं होता. So you can see STEMI patient who is a candidate for reperfusion initially seen at the PCI capable hospital, sent to the cath lab for primary PCI. First medical contact device time is less than 90 minutes. First medical contact मतलब आप BR पे आपसे मिला है तो within 90 minutes आप PCI उसकी कर दी है. So this is class 1 recommendation. Do a diagnostic angiogram and put a stent in that patient, and you are saving the life. But if initially the patient is seen at the non-PCI capable hospital, for example in DHQ heart, then the door in, door out time. For example, the patient presented to the ER, his ECG has been done, he has been given the initial ACS protocols, that is the loading dose, dual antiplatelets, anticoagulation. उसको यहाँ से ट्रांसफर करना टर्शियरी केयर हॉस्पिटल शुड बी लेस देन 120 मिनट्स, लेकिन यहाँ से जब वो पीछा हो जाते हैं तो 2 घंटे से ज़्यादा टाइम लगता है. ठीक है, तो ट्रांसफर PCI First, medical contact device time as soon as possible should be less than 120 minutes. Administer thrombolytic agents within 30 minutes of arrival when the anticipated time is more than 120 minutes. और जब उनको इसके लग जाए, स्टेबल हो जाए, तो 2 से 24 घंटे के दौरान आप उनको ट्रांसफर करें हॉस्पिटल ताकि उधर उनकी इंटरवेंशन हो। तो सिंपल है, आपके पास पेशेंट है, विदिन 90 मिनट्स पीसीआई कैपेबल हॉस्पिटल है, एंड यू करेक्ट। अगर पीसीआई कैपेबल हॉस्पिटल नहीं आया, तो हार्ट में आया, तो कोशिश करें कि अगर वो यहाँ से उधर 2 घंटे के अंदर अंदर पहुँच सकता है, तो इट इज गुड। नहीं तो आप फार्मेको इन्वेजिव स्ट्रेटेजी, आप उसको यहाँ पे थ्रोम्बोलिटिक्स दें और उससे 2 से 24 घंटे के दौरान उसको शिफ्ट करें। अगर 24 घंटे से टाइम ज्यादा हो जाता है और पेशेंट हीमोडायनेमिकली स्टेबल है, तो शिफ्ट नहीं करना। ठीक, अगर स्टेबल नहीं है, उसने हार्ट फेलियर डेवलप किया है, उसने क्रैक्स डेवलप किए, क्लिप क्लास 2 में आ गया, कार्डियोजेनिक शॉक में आ गया, रिफ्रैक्टरी एंजाइना है, आपने उसको स्ट्रेप्टोकाइनेज दे दिया, उसके बावजूद भी उसको पेन हो रहा है, तो आपने ऐसे पेशेंट को फिर ट्रांसफर कर। अब हमारे यहाँ पे स्ट्रेप्टोकाइनेज दी जाती है जो दुनिया में ऑब्सोलीट हो चुकी है, वो नहीं देते, लेकिन हम देते हैं, हमारी मजबूरी। What is the limitation of streptokinase? Streptokinase is an older and non-fibrin specific agent. It achieves the complete reperfusion in only about 50 to 60% of patients who are treated. मतलब अगर हम 100 पेशेंट्स को ट्रीट करें, तो इसका 90% पेपेटेंसी रेट 50 to 60% है एक इंडिविजुअल, तो 40% ये रिमेन एक्लूडेड रहेगा। There is a high risk of systemic bleeding and allergic reactions. Repeat use is problematic. आपने एक पेशेंट को स्ट्रेप्टोकाइनेज दिए, आज वो ठीक है, एंटी-1MI 2 दिन बाद वही फिर 1MI डेवलप कर ले, आप उसको स्ट्रेप्टोकाइनेज नहीं देते, क्योंकि इसके खिलाफ एंटीबॉडीज डेवलप हो जाती हैं, वो फिर इम्यून मेडिएटेड रिएक्शंस डेवलप करते हैं, एलर्जिक रिएक्शंस डेवलप करते हैं। So globally it has largely been replaced by PCI on newer fibrinolytics like antiplase, retiplase, tenecteplase, उससे इसको वो कर दिया। आप देख सकते हैं एक पेशेंट को स्ट्रेप्टोकाइनेज में So, according to American Heart Association and ACC guidelines, primary PCI is a class 1 recommendation for STEMI. Fibrinolysis is recommended only when PCI cannot be performed within the guideline recommended time frames. This reflects the overwhelming evidence favoring mechanical reperfusion. Now, who should undergo PCI? जो मैंने पहले बताया था, those who present within the 12 hours of STEMI, having cardiogenic shock, failed thrombolysis, contraindication to lysis. In these patients, the PCI is life-saving. When immediate PCI is not possible, a pharmacoinvasive strategy is recommended. This involves early fibrinolysis followed by the routine angiography and PCI within the 2 to 24 hours. Initially it was 3 to 24 hours, now it is 2 to 24 hours in latest 2026 guidelines. This approach significantly improves the outcome compared to the thrombolysis alone. So what challenges we are facing in Pakistan? Our challenges are real and understandable. Patients present late, transport is delayed, and tertiary care centers are far away. However, these challenges actually strengthen the argument for developing the local PCI capability rather than relying on the distant reference. So it is a need of the day to have this angiography lab, cath lab in our hospital. DH2 hearts serve as a large population with high cardiovascular risk. Daily referred to the Peshawar overburden both the patient and the healthcare system. Many patients deteriorate during transfer or never make it to the PCI at all. The solution is not theoretical. It is always practical. Establishing cath lab services will allow timely reperfusion, reduce the referrals, and dramatically improves the outcome. This aligns with our status as a teaching hospital man. A structured STEMI protocol ensures efficiency and safety. From early ECG diagnosis to activate the cath lab in time, the door to bedroom time should be less than 90 minutes. The door to bedroom time मतलब ये है कि जब हॉस्पिटल में पेशेंट आ जाए और आप फर्स्ट एंजियोग्राफी करके वाइड आर्क में बेडरूम इन्फ्लेट करें, तो इसको डोर टू बेडरूम टाइम, it should be equal to less than 90 minutes. And there should still be a backup for macro-invasive plan with you. Now what are the expected benefits? Obviously it will reduce the mortality, it will reduce the heart failure, it will be shorten the hospital stay, and there will be good long-term prognosis. While cath lab setup requires investment, the long-term savings are substantial. And we will save the patient from referring them to pathology. Local PCI services reduce the patient's suffering, financial burden and delays. And remember, it will enhance the public trust in DH2 hospital as a tertiary care center. This is not just about Tulesa, it is about building DH2 Hospital Kuhart as a regional cardiac center for the future, center of excellence. These recommendations are firmly based on AHA, ACC and STEMI guidelines. I have discussed these trials. So in conclusion, ma'am, STEMI care at DH2 Kuhart can and should be improved. Primary PCI is no longer a luxury, it is the standard of care. And with our existing human resources, we are well positioned to take this step forward. Thank you.
आपकी जो प्रेजेंटेशन है ना वो दो